Dr. Arion, Senior Health Education.
Robert Callahan was 63 years old, a retired civil engineer from Portland, Oregon. He was the kind of man who scheduled his annual physical the same week every year, who tracked his cholesterol numbers in a notebook, who walked 45 minutes every morning without fail. He came to me in November, not because something was wrong, but because something felt slightly off. He couldn't name it. His wife had convinced him to come in. He almost didn't. He told me he'd been a little more tired than usual, waking up at night, some mild indigestion after dinner, a strange heaviness in his left arm when he reached up to the kitchen cabinet. Each symptom on its own meant nothing. He had told himself that. He had Googled each one separately. Acid reflux, fatigue, getting older. Perfectly reasonable explanations. And every single one of those explanations was wrong. Pause. 6 weeks earlier, Robert's left anterior descending artery, the one cardiologists call the widowmaker, had begun its final narrowing. The plaque that had been building for years was now unstable. A thin cap of fibrous tissue was all that stood between Robert and a massive heart attack. And it was cracking. Here is what nobody had told Robert, and what I am about to tell you. A heart attack does not arrive without warning. In the majority of cases, the body begins signaling 30 days in advance, sometimes longer. But those signals have been described to most people in ways that are almost completely useless. Chest pain, shortness of breath, as though a heart attack announces itself like a fire alarm. It doesn't, it whispers. And most people, intelligent, attentive people like Robert, mistake the whisper for ordinary noise. By the end of this video, you will know exactly what those 5 whispers sound like, how to recognize them in your own body, starting tonight, and what I recommend you do if even one of them is happening to you right now. Think of your cardiovascular system the way you think of a garden hose that has been in use for 60 years. When it was new, the walls were flexible. They expanded under pressure and snapped back. Water moved through cleanly, smoothly, but over decades the rubber hardens. The inside of the hose begins to accumulate mineral deposits. The walls thicken in some places and thin in others. The hose still works. Water still flows, but it is playing by entirely different rules than it did at 30 years old. Now put that hose under the same pressure as a new one. What happens? This is what your heart and arteries face every single day after 60. The system still functions, remarkably well in fact, but its margins have changed. It has less room for error. And when something begins to go wrong inside that system, the signals it sends are quieter than they used to be, more diffuse, easier to dismiss. Because the body at this age has learned to compensate. It is skilled at hiding trouble, right up until the point when it cannot. The reason I'm telling you this is not to worry you. It is because the body still responds. The same system that compensates quietly can also be listened to carefully if you know what to listen for. And that knowledge changes everything. I'm Dr. Arion. I've spent more than 25 years practicing cardiovascular and internal medicine, in operating theaters, in consultation suites, in recovery wards where I have sat with patients and their families after the thing happened that we were all trying to prevent. What I have seen, over and over, is that the warning signs were there. They were present. They were simply not recognized for what they were. Senior health education exists because a 12-minute appointment is not enough time to give you what you are about to hear. Eleanor Marsh was 67, a former high school librarian from Birmingham, England, who had retired 2 years before and spent her days gardening and looking after her grandchildren. She came to me in March describing what she called bone tiredness. Not sleepiness, tiredness. She was sleeping 8 hours and waking exhausted. Her GP had checked her thyroid. It was fine. Her iron was fine. She had been told, gently, that this was simply what getting older felt like. She sat in my consulting chair and said, "I don't believe that." She was right not to. When a coronary artery begins to narrow significantly, the heart has to work harder to push the same volume of blood through a smaller opening. Think of squeezing water through a partially kinked hose. The pump at the end has to exert far more force to maintain the same output. Your heart is that pump, and when it is working 20–30% harder than it should, the rest of your body pays the price. Blood, and with it oxygen, is being diverted to keep the heart itself functioning. Your muscles receive less. Your organs receive less. The result is a pervasive, whole-body fatigue that no amount of sleep can fix, because sleep is not the problem. Circulation is. Emphasis. This fatigue feels different from ordinary tiredness. It is present in the morning before you have done anything. It does not lift after rest, and it has no obvious explanation. A 2019 analysis published in Circulation, the Journal of the American Heart Association, examined pre-infarction symptoms in 567 women who had experienced a first heart attack. 70.7% reported unusual fatigue as the most prominent symptom, not chest pain, appearing on average 4 weeks before the cardiac event. Here is what most doctors simply do not have time to explain in a standard appointment. Fatigue is not just a symptom of exhaustion. In a person over 60 with any cardiovascular risk factors, fatigue that is new, persistent, and unrelieved by sleep is a cardiovascular signal until proven otherwise. This is in the literature. It is not taught loudly enough. Keep a fatigue log for 7 days. Write down, each morning before you get out of bed, a single number from 1 to 10, how rested you feel. If that number is below 5 for 5 or more consecutive mornings, and you are sleeping adequately, that pattern needs to be in front of a doctor this week, not at your next annual checkup. When did you last wake up feeling genuinely restored? Not okay, genuinely restored. I ask every patient over 60 this question. Most of them have to think for a long time before they answer. James Okafor was 61, a retired police sergeant from Toronto, broad-shouldered, measured, not a man given to unnecessary worry. He had been managing what he described as a bit of acid after dinner for about 6 weeks. He had switched to lighter meals. He had tried antacids. He came in only because his daughter, a nurse, had looked at him across the dinner table one Sunday and said, "Dad, go." He almost didn't. The heart and the esophagus, the tube that carries food from your throat to your stomach, share a nervous pathway. They are literal neighbors in your chest, separated by very little. When the heart muscle is receiving insufficient blood flow, it sends distress signals along nerve pathways that the brain sometimes interprets as digestive discomfort. The technical term is referred visceral pain, pain that originates in one organ but registers in the nerve territory of another. What this means, practically, is this: a burning sensation in the mid-chest, a feeling of fullness, nausea without vomiting, or a sensation that something is stuck. These can be the heart's distress call, filtered through a nervous system that misroutes the signal. Emphasis. The critical distinction is this: cardiac indigestion tends to come on with physical exertion or emotional stress, not only after eating. And it does not reliably respond to antacids. Research published in the European Heart Journal found that among patients who presented to emergency departments with what they believed was gastrointestinal distress, 8.4% were experiencing an active cardiac event at the time of presentation. These were not statistical outliers. They were people who had been managing acid at home for days. Nobody talks about this in a consultation room the way they should. When a patient over 60 describes new, persistent chest or upper abdominal discomfort, particularly if it comes on during walks, climbs stairs, or moments of stress, that is a cardiac symptom in my mind until I have ruled it out. The burden of proof runs in one direction. Always. If you have had what you are calling indigestion for more than 2 weeks, particularly if it occurs at times that have nothing to do with food, stop treating it as a digestive problem. Tell your doctor specifically when it happens, not just that it happens. That context is the difference between a prescription for antacids and an EKG. Have you been reaching for antacids more often in the last month? And does it happen at times when you haven't eaten? That second part, that is the question that matters. Patricia Lung was 69, a former accountant from Sydney, meticulous and precise. She had started waking between 2 and 3 in the morning, not to use the bathroom, not from a dream, simply awake, with what she described as a vague restlessness and occasionally a feeling she could not quite name, somewhere between anxiety and physical discomfort. She had been told it was menopause-related sleep disruption. Patricia had been postmenopausal for 19 years. Blood pressure follows a circadian rhythm, a 24-hour biological clock that governs nearly every system in your body. In healthy individuals, blood pressure dips by 10 to 20% during sleep. This is called the nocturnal dip, and it is one of the most protective events in your cardiovascular day. In people with developing coronary artery disease, this dip is often blunted or absent. Worse, in some patients, blood pressure actually rises in the early morning hours, a phenomenon called reverse dipping, placing enormous stress on arteries that are already compromised. The heart, working against this pressure, struggles. The sympathetic nervous system, your body's alarm system, activates. You wake up. You don't know why. You lie in the dark feeling vaguely wrong. And then, because it passes, you tell yourself it was nothing. Pause. It was not nothing. A landmark study published in the Journal of the American College of Cardiology, following 3,175 adults over a 6-year period, found that non-dipping blood pressure patterns were associated with a 2.4-fold increased risk of cardiovascular events compared to patients with normal nocturnal dips, even when daytime blood pressure readings were within normal range. Here's the thing that frustrates me. Most blood pressure monitoring happens in the morning, in a doctor's office, with the patient seated and calm. That is arguably the least useful reading for detecting nocturnal cardiovascular stress. The reading that matters most is the one nobody takes, the one at 2 in the morning, when your heart is working hardest against a pressure it should be resting from. If you own a home blood pressure cuff, and after 60, you should, take one reading at your normal morning time, and one reading immediately when you wake in the middle of the night. Write both down for 2 weeks. Bring that paper to your doctor. Those two numbers together tell a story that a single office reading cannot. Are you waking at night and telling yourself it is nothing? How long have you been waking this way? Write the honest number down, not the comfortable one. Gerald Ford, not the president, a 65-year-old secondary school history teacher from Edinburgh, came to me with what he was convinced was a dental problem. His lower jaw ached intermittently, particularly when he walked uphill on his morning commute. His dentist had found nothing. He had been referred to a physiotherapist for his neck. He arrived in my office almost apologetically, as though he were wasting my time. He was not wasting my time. The heart receives its sensory nerve supply from the same spinal segments that serve the jaw, neck, both shoulders, and the inner aspects of both arms. This is not a design flaw, it is simply anatomy. When the heart muscle is ischemic, meaning it is not receiving enough oxygen-rich blood, it sends pain signals along these shared pathways. The brain, which has far more practice processing jaw pain and shoulder pain than heart pain, sometimes routes the signal to the more familiar address. The result is discomfort in the jaw, the neck, one or both shoulders, or down the inner arm, with no structural cause in any of those locations. The cause is elsewhere. The cause is the heart. Emphasis. The cardinal feature of this symptom is that it comes and goes with exertion. It worsens when you walk briskly or climb stairs. It eases when you rest. That pattern, in a person over 60, is angina, insufficient blood flow to the heart muscle, until proven otherwise. Data from the British Heart Foundation's National Audit of Heart Attack Presentations found that approximately 27% of patients who experienced a myocardial infarction reported jaw, neck, or shoulder discomfort as a prodromal symptom, meaning it appeared in the weeks before the event, without accompanying chest pain. This symptom is dismissed more than almost any other. Dentists treat it as dental. Physiotherapists treat it as musculoskeletal. And patients who have been told all their lives that a heart attack feels like an elephant on the chest do not connect the two. I am telling you directly, unexplained jaw or shoulder discomfort that correlates with physical effort is a cardiac symptom until a cardiologist tells you otherwise. The next time you feel discomfort in your jaw, neck, or either shoulder, note exactly what you were doing at the moment it started. Were you walking? Carrying groceries? Climbing stairs? Feeling stressed? If the pattern repeats, if it comes with exertion and leaves with rest, that information needs to reach a physician today, not when it is convenient. Have you had unexplained jaw or shoulder aching and told yourself it was tension? I want you to think about whether it happened when you were physically active. That one detail changes everything. Dorothy Simmons was 66, a retired district nurse from Manchester, a woman who had spent 40 years on her feet, who had never been sedentary a day in her working life. She came to me because she had become breathless making her bed. Not after a run, making her bed. She had told herself she was deconditioned, that she had been too sedentary since retirement. She was ashamed of it almost. That shame had kept her from coming in for 4 months. When coronary artery disease reaches a point where the heart can no longer pump efficiently at even modest levels of exertion, fluid begins to back up into the lungs, a condition called early pulmonary congestion. The alveoli, the tiny air sacs where oxygen crosses into your bloodstream, become partially waterlogged. Not dramatically, not enough to cause the alarming breathlessness most people associate with heart failure, but enough to create a subtle, persistent sense that breathing requires more effort than it should. The body compensates magnificently. It reduces your activity level before you consciously decide to. You stop taking the stairs. You park closer. You sit down between tasks you used to complete standing. And then one day you notice that what used to take no thought now takes effort, and you cannot quite explain when the change happened. Emphasis. This gradual recalibration of what you consider normal is one of the most dangerous aspects of cardiovascular decline after 60. The body hides the evidence by changing the standard. A prospective study in the New England Journal of Medicine following 4,814 adults over age 60 for 8 years found that new-onset exertional dyspnea, breathlessness with physical activity, was associated with a 3.1-fold increased risk of major adverse cardiovascular events within the following 18 months, even in individuals with no prior cardiac diagnosis. This is the symptom patients are most likely to rationalize away because it has 100 innocent explanations that feel more comfortable than the real one. Deconditioning, weight, allergies, a bad mattress. I am not dismissing those possibilities, but I am telling you this: if you are more breathless than you were 6 months ago doing ordinary things you did without thought, that change requires an explanation. Not a rationalization, an explanation from a physician with tests. Pick one ordinary physical task you do every day: making the bed, climbing the stairs in your home, walking to the letterbox. Time yourself doing it today. Rate your breathlessness on a scale from 0 to 10 immediately after. Do this for 2 weeks. If the number is trending upward, or if it is consistently above 4 for routine activity, that chart goes with you to your next appointment, and you make that appointment this week, not next month. When did you last do something physically effortful without thinking about how your breathing felt afterward? Think back. How long ago was that? Let me stop here for a moment. I want to tell you about a patient whose name I will carry with me until I retire. Her name was Margaret Holloway. She was 71 years old, a retired music teacher from Bristol, who had been widowed 8 years before and was, in her own words, just beginning to enjoy her life again. She had a daughter in Vancouver she was planning to visit. She had started learning watercolor painting. She had just finally booked the trip. Margaret came to me in the spring. She had been experiencing unusual fatigue for 3 weeks, some nighttime waking, and what she called a funny feeling in her jaw when she walked to the post office. She had not come in about those symptoms. She had come in for a repeat prescription. I asked her about the jaw discomfort almost by accident, something she mentioned at the end of the appointment. I almost didn't ask the follow-up question. It was a busy day. She was already standing up. I asked her to sit back down. We ran an urgent stress test. Her left anterior descending artery was 92% occluded. She was admitted that afternoon and underwent stenting the following morning. She went to Vancouver 6 weeks later. Pause. She sent me a photograph from Stanley Park. She is standing beside her daughter, smiling with the mountains behind them. That photograph is in my desk drawer. I look at it on the hard days. What I think about, what I have thought about ever since, is what would have happened if I had not asked the follow-up question. If she had not mentioned the jaw, if she had decided not to come in at all that day, as she almost didn't because she didn't want to make a fuss. Emphasis. The signs were there. They are almost always there. The only question is whether someone is listening and whether you feel you have permission to take them seriously. You do. You have that permission. You have always had it. Here is what I want you to take from today. Specific, concrete, and starting tonight. 1. Begin a morning fatigue log tonight. Before you rise tomorrow, rate your rest from 1 to 10. Do this for 7 consecutive days. If you average below 5, that pattern sees a doctor within the week. 2. If you have been experiencing chest or upper abdominal discomfort you have been calling indigestion, note carefully whether it occurs with exertion, not just with food. If it does, that is your signal to stop treating it as a digestive problem and start treating it as a cardiac question. 3. If you are waking at night, regularly, for no clear reason, with any accompanying discomfort or restlessness, take your blood pressure at that moment if you have a cuff. Write both the time and the reading. 2 weeks of nighttime readings alongside your morning readings tells a doctor something a single office visit cannot. 4. If you have unexplained jaw, neck, or shoulder discomfort, particularly if it comes on during physical effort and eases with rest, do not wait for your next dental appointment or physio session. Call your doctor's surgery tomorrow morning. 5. Pick one daily physical task and begin rating your breathlessness immediately after completing it on a scale of 0 to 10. Track it daily. If it is consistently above 4 or trending upward over 2 weeks, that information goes to your doctor this week. And the overarching instruction, the one that matters most, if 2 or more of these signs are present at the same time, do not wait. That is not caution. That is mathematics. Multiple simultaneous signals from the same system are not coincidence. I want to ask you one thing before you go. Of these 5 signs, the fatigue that sleep doesn't fix, the indigestion that isn't, the 3 a.m., waking, the unexplained jaw or shoulder discomfort, the breathlessness doing ordinary things, which one did you recognize in yourself while I was talking? Tell me in the comments. I read every single one, and I answer as many as I can. Your answer might help someone else watching recognize it in themselves. If someone in your life is over 60, a spouse, a sibling, a close friend, please share this video with them, not as a worry, as information, the kind of information they deserve to have. If you haven't subscribed to Senior Health Education yet, now is the time. Every week, I bring you the honest information I wish every patient had before they needed a specialist. I'm Dr. Arion. Take care of yourselves. Everything I've shared today is grounded in published research and more than 2 decades of clinical experience. But you are not a statistic. You are a person with your own history, your own medications, and your own physician. Before making any changes to your routine, or if any of these symptoms are happening to you right now, please have that conversation with your doctor. Bring this video if it helps start the discussion. Your doctor is your partner, not your opponent. And you are not wasting anyone's time by asking,